Thank you, Uli. So a little background again, I'm a physician, I'm a technologist, I'm a health services researcher. I've been spending really the past 20 years thinking about how technology can be used to improve health outcomes. So really looking at access to care, quality of care, improving the overall patient experience, and finding ways that we can make care more efficient. And so as part of that journey, I've been spending a lot of my time thinking about first the inpatient side, and that's really where much of my earlier work started. We used to have studies where we'd have nurses run around the hospital and they would identify patients that were low risk, especially low risk for perhaps being discharged from the hospital or being stepped down from the ICU to the ward. And as we went through that journey, we realized that we could influence decisions if we gave the right information at the right time. Now the problem was that after all these great studies, and many of these were published in peer-reviewed journals, the fact that we didn't have an active intervention, the baseline rates always returned back to normal. So a really good example would be when we did our study on pneumococcal vaccinations for the VA, we improved the vaccination rate during the time of the study from 20% to well over 80%. And this is during the summer months. But then as soon as I packed up my bags and we started looking at other areas, I went back down to 20%. So really what you needed was a sustainable process, a mechanism where clinicians could get that level of support. And that really was the foundation for the clinical decision support systems that we built. This is really early pre-meaningful use. So at the time, there really wasn't a whole lot of concept around what CDS was. So much of what we were doing was at the time trying to reinvent or redefine what clinical decision support was. We built a database, and this is when I was a fellow and then an attending at Cedars-Sinai and UCLA, and that ultimately became a company which was owned by Cedars, and then we were acquired by Cerner. And in large part, that journey allowed me to better understand how this type of technology and this type of approach could actually be used within a clinical workflow. And then over the past many years thereafter, we started seeing a growth of the electronic health record, really driven by meaningful use. And because of that, we saw a tremendous interest in terms of understanding how these tools could be used by clinicians and other health organizations to improve health outcomes. But the reality is, as we looked at sort of the things that Uli had talked about, we couldn't really impact things that were outside of the hospital. So, how do we get patients healthier? How do we prevent the readmissions? And we really needed to think beyond the support systems that we had to applying a clinical decision support system for consumers, for patients. And so as part of that journey, I really realized, I came to realize that we don't have within the electronic health record and patient portals an access point for clinicians, or I should say for consumers, to be able to get that same type of support, not so much in their workflow, but in their lifestyle, because it's all about workflow compatibility for physicians and lifestyle compatibility for consumers. And so as you think about that, what is it that's lifestyle compatible? Your smartphone is, your TV, all the things that you use every day, your home appliances. This is what is compatible to us. This is what we deal with every single day. Here's the information that we're gathering. We're gathering it from these devices, from things around us. And right now, all those devices have sensors on them, and they have transmitters, and they allow us to be able to send that to places that allow us to be able to make some sense out of that. And so as part of that really kind of realization that we have an opportunity to tap into the amazing things that are happening in the world, in the consumer tech world, that's when I joined Samsung, which is about 6 years ago. And part of that journey was really looking at how this technology could be used to essentially gather information of what's going on, better inform consumers, and connect them to healthcare providers to lead to better outcomes. So what I wanted to do is I wanted to talk to you about some of those technologies that we have already not only been developing, but in many cases we've validated. And I'll share with you the studies and some of the impressive results that we, through our partnerships, have been able to accomplish. And I think much of this is related to the fact that we've got some really innovative groups of people and organizations that are thinking about how these technologies can be used for consumer and clinical care. So that said, let me jump into first, kind of as we think about from the Samsung perspective, we've been looking at it from first the hospital perspective, and now we're starting to think about, in the daily life, what we refer to as our InHealth approach, What are these ways? Which oftentimes ties into like we'll call connected health solutions, wearables, sensors. But then really it's about what's also available at home, and those are sensors that are also in the home. These could be connected to your refrigerator, could be connected to your TV. And so this whole approach from going from in-hospital to in-health to in-home is a big spectrum of activity. So what I'll do is I'll try to provide you with some examples in each of the different areas that will give you a sense as to what's out there and what some of these innovations look like. So let's first talk about an experience that we've been working with a healthcare organization, which I can't unfortunately name today, but I think some of you may know. It is a large IDN that has been thinking a lot about value-based care. And as part of this journey, they have recognized that individuals who've had a heart attack, while they may in fact be recommended to have cardiac rehabilitation, in fact the completion rate for this program is very low. And if you do look at nationwide surveys, it's typically less than 50%. So what that means is that there's about more than 50% of individuals who don't complete these programs. So what does that really translate to? When we talked to several of the cardiologists, we realized that this is an important program, especially after you've had a heart attack or if you're at higher risk for these conditions, for bad events, that there's something called a number needed to treat of 4. And I've seen numbers closer to 18, but this is what the cardiologists and others were telling us. They said, for every 4 patients that complete this program, you save 1 life. So in other words, for every 4 patients that don't complete this program, you're basically losing a life. So what we really want to do is we want to improve that completion rate, which is traditionally less than 50%, and get that much higher. And what we realized is when we looked at cardiac rehab, the concept of rehab was typically one where, oh my gosh, these are individuals who've had a heart attack. You're going to have to put on a Holter monitor or some kind of have defibrillators nearby. But that actually isn't what most cardiologists are looking at when they look at cardiac rehab. What they're looking at is this individual exercising? And are they exercising at a low rate or a moderate rate? Or are they highly active? Are they active every single day? Are they having any symptoms? Are they taking their medicines? And as part of that discussion, we realized that this isn't about putting FDA certified devices on them and putting all this monitoring to see if they're looking for arrhythmias, but it's really more around, do we have an ability to coach individuals to better health? And when we came to that realization, we realized that that can be done on a consumer device such as a smartwatch. In fact, this is the Gear S2, and this is the watch we used initially for our first pilot. And what we did is we virtualized that entire program onto the smartwatch. So every day, an individual would get an alert or a message that says, hey, we need to do a 6-minute walk test. So you do the walk test, see how far you can go, then you do a cool down period, you see if you have any symptoms, no chest pain, no shortness of breath, good. Periodically you'll get a medication reminder throughout the day. Every single day you do this for the next 6 weeks. Went from a baseline rate of 48% to a new rate of after the completion of this program to 83%. So almost a doubling of the completion. And again, with the number needed to treat of 4. And when we asked patients and we asked the clinicians, what was your experience? It was incredible. The net promoter scores were extraordinarily high. The patient satisfaction rates were high because what was happening is they were able to do this program without having to go into the facilities. And if you can think about the inconvenience that we've made, or how difficult we've made it for patients to be able to complete these programs, we assume it's easy because, hey, it's in our facility, it's at our time. But for those individuals, they've got jobs, they've got families to take care of, it might be certain costs, certain travel, it's a certain time away from everything. It's difficult, especially if you're asking for multiple times throughout the day, throughout the week, for 6 weeks straight. So what we realized is that huge opportunities when we start thinking of the consumer first as opposed to the clinician. And that has ultimately gotten us thinking about other ways that we can apply some technologies in ways that we hadn't envisioned. And one of the areas is looking at tools like virtual reality. What we found in virtual reality, most people think of VR as a great way to distract or entertain, and it certainly is. And in fact, we've seen cases where in a hospital, people might use this just to kind of escape from the fact that they're not in a place that they don't want to be in. or if you have an opportunity to train individuals, and we were just talking earlier about how these tools can be used to train surgeons and cardiologists to do procedures, and tremendous opportunities. But what we hadn't realized is that we could actually use these tools to actually make pain go away. We could alleviate pain. And it was incredible when you would have these individuals put this on, take it off, and even for 1 to 2 hours thereafter, they would have sustained pain relief. So what we wanted to do is we wanted to do some clinical trials on this. And we've actually had multiple clinical trials, but most recently was a randomized control trial that was published, or I should say completed at Cedars-Sinai. 120 patients randomized. These are hospitalized patients with pretty much moderate to severe pain. These are post-operative patients, sickle cell pain crisis, pneumonia, cancer, things that traditionally require opiates. And in this group, what we realized is that if you randomize them to the VR, and then the control group actually watched the same type of content on a TV screen. So it really wasn't the content, it was about the immersive experience. And what we saw was a 52% reduction in pain in the intervention group that received the VR. And even after they took the headsets off, we saw a significant improvement. And with functional MRIs that were done in another study on these individuals, we saw dramatic improvements, or I should say dramatic changes, where even when patients had pain, it would light up like a Christmas tree, but even when you took it off, you'd see it quiet down. So that meant that there's actually some neurochemical changes going on in conjunction with what's going on. So it wasn't just distraction, because we were actually seeing the changes, and even after you're taking the headsets off, you're seeing this persistent pain relief. And what we realized is that this could be potentially an opportunity for us to address issues like the opioid epidemic. You have a question here?
A very
yes.
good question that the comment that you had. How does somebody visibly looking at something impact the pain itself?
Great question. So the question is, if a person's looking at something, how could that actually impact one's pain? So the first thing is that the content that they're watching is also synchronized with music, and it is oftentimes calming type of videos, like I'll show you a picture of here. You're swimming with the blue whales, you're flying over beautiful topographies, and as part of that experience, it puts people into a better state of mind. And as part of that, we're recognizing that somehow breaks the pain cycle, that immersiveness. We know that this is something that's a very powerful tool. What we realized is that the individuals that have this, in many cases, they're trying to get rid of the pain, but they can't because of the fact that it's just so overwhelming. But when you actually can break the pain cycle, they oftentimes are able to think about what happened and re-experience that. And then using these mindfulness techniques, they've been able to recreate. So the interesting thing is these type of studies have actually been performed in several instances. So I shared with you the randomized control trial at Cedars, which has been submitted for publication. But there are actually meta-analyses on this, and so this is not new. I shared with you that functional MRI changes. If you look at the top row, you'll see how it's all yellow. That just indicates these are individuals with pain, no VR, high level of activity. With the VR, even after you've taken the headset off, it quiets down. So there's more to it than just simply distracting one from their pain. And so what we've recognized is that VR could be an amazing tool. What we also have seen is that it could be used for other clinical conditions. And one that we hadn't anticipated is the use of virtual reality to address low vision, specifically conditions like macular degeneration, retinosa pigmentosa, even glaucoma. And what we're finding is that the reason why it addresses it, because what we didn't realize is that the human's body actually has a resilient nature to it. It has an ability to use other parts of the body to overcompensate or to compensate for defects. So if you think about macular degeneration, as we all know, there's damage to a part of the eye, the retina, that causes central blindness. And that area that's damaged is something that will continue to grow, and unfortunately there's not a whole lot that we can offer that will essentially eliminate that. We can try to reduce the growth of it, but it ends up becoming one that progressively leads to blindness. But what we've realized is that there is something called the preferred retinal locus, which is just off to the side, a small area that is oftentimes hard to locate, hard to latch onto, and sometimes a little small to see. But when people do see it and latch onto it, they actually can get some good visual acuity. So despite the fact that instead of using the rods in the middle, you're using the cones off to the side, or just the cones in the middle and the rods off to the side. You have an ability now to be able to sort of latch onto that and be able to find a higher level of visual acuity. And what we found is that using technology, we can actually help the individual do this. And so here example is, if you look on the left-hand side, the macula, sort of in the middle area, where you've got the damage in the middle, but the PRL off to the side. Now imagine an individual putting the VR headset on, they look over, and then with eye tracking software, it allows them to latch onto it. And then the technology on the VR headset allows you to magnify it and be able to present that image with greater clarity. But then there's a variety of individuals that have photosensitivity, color sensitivity, and you can make those adjustments also. So in a study at Johns Hopkins where they looked at this, they found that the individuals that had this AMD and they were using this technology, an improvement in their vision of 2400 at baseline to 2030 with the technology. A dramatic improvement. I mean, we're talking about literally legally blind to able to see. And as you can see through these other areas, their functional capacity to do a variety of other things improved. What's remarkable about this is that this is actually being used by over 80 ophthalmology centers across the country. Stanford's using it, Johns Hopkins, Cleveland Clinic, UCLA. The reality is most people only within the certain subset of that domain really know about it. So what we're realizing is that sometimes these technologies people don't even know about, even within the medical community. And what we're trying to do is we're trying to really understand more about how we can better disseminate news and information about that, not only to the healthcare provider world, but also to the consumer world. So now let's shift gears and talk about outside of the hospital, because outside of the hospital, there's a lot of talk about how we can use sensors and technologies. But the reality is, if you give a person a smartwatch, after about 3 months or so, or 6 months, people will just stop using it. Most of them. About a third of them will stop almost immediately or within 3 months because of the fact that they kind of know what to expect. There's really not a whole lot of information that they're gathering that's going to change their lives. So the desire to use this is very important. You need to understand what's the underlying motivation. And so when you look at groups like seniors, who oftentimes we assume that they'll either not adopt technology, or if they will adopt technology, it'll be extraordinarily difficult. What we realize is that that's not always the case, and especially as individuals continue to age, the number of tech-savvy seniors will continue to increase as well. But that still doesn't get around the fact that people will not want to wear a smartwatch just for tracking their steps. Change the paradigm. Instead of wearing a smartwatch to track your steps, give them the ability so that they allow them to live independently. How do you do that? Put a PERS system on this, a personal emergency response system. So that now, instead of having a life alert on your pendant on your chest, what you have now is this mechanism where if you're ever in trouble, you push a button, and then there's sort of like this OnStar where they'll call you. You could be falling to the ground. You could talk to it, get somebody there. It has GPS locations. It sends a signal with exactly where you're located. That's right now being deployed. And with that type of technology, you can also see if they're wearing it. You can see where they're located. You can do geofencing for individuals that might have cognitive decline and you're concerned that they might be going out of certain areas. And those are the types of solutions that we're starting to see deployed in senior centers and in groups that we had never used technology, because we changed the whole value proposition from it being a tracking device to one that actually provides an ability to live safely and securely at home. And that's what we're starting to recognize, that if you're going to want to apply these technologies in these settings, it's got to be something that they either want to do, or it's got to be behind the scenes and invisible. And so here's another example of something that we recognize that there might be an opportunity to take a look at motion sensors. And could those motion sensors help us in terms of providing greater opportunities to identify risk? So on the topic of artificial intelligence, there is a hypothesis that individuals who are sicker tend to sleep longer. They tend to go to the bathroom more frequently. They tend to go to the bathroom in the middle of the night. They tend not to take their medicines regularly, if at all. They tend not to eat or drink as much. They tend not to be as active within their home or their living space. So with motion sensors, we can actually determine changes in their baseline activity to the point where if we see those changes, we may be able to intervene early. So how do we know this? We did a study, or our partners did a study. 40 sites in the state of Michigan. These are independent living. We took a look and identified if there were changes in the baseline. And they hired a $12 per hour home health aide nurse to determine if there was something going on. They would just give them a call, or they'd stop by. And that simple triaging mechanism identified things where that could potentially have led to ER visits. And so during this 1-year period, they experienced an 80% reduction in ER visits using these really easy, inexpensive sensors with some basic AI technology behind it. And that's what's so interesting about it, because we didn't do all the things that we traditionally think of having all these extensive monitors and doing all these things. We just basically made it super easy. And nobody wants to have video cameras in their house for watching, but they don't mind having a few motion sensors, which they probably already have anyways for the lights when you walk into the door anyways. So that's the type of stuff that we're starting to recognize is going to be highly valuable. The other thing that we're seeing is that can you take advantage of some of the folks who are doing work that is healthcare related, and capturing information, but really not helping us inform decision making. And I'm specifically talking about caregivers that are non-healthcare professionals. So these are family members. These are individuals that take care of your loved ones. And in fact, many times, if they had the tools, they could provide us with meaningful information. So how do we know that? Well, again, they've been doing a lot of studies with the use of newer technologies. And one of those technologies is called e-caring. And so what they did is they took a tablet and they said, okay, we're going to put all the ADLs, all the tracking around whether an individual is eating well or sleeping well or whether they're having any challenges. And we'll put emojis. It'll all be based on emojis. So grandma, looks like you didn't eat your whole meal. We're going to give you one frowny face emoji. Okay, grandma, how you feeling? You don't feel so good? Okay, I'm going to give you another frowny face. And then these data points are actually being analyzed on the back end with an analytics platform that as someone is then going to follow up and say, hey, it looks like grandma has actually gotten a deterioration in her mood and her diet over the past couple of days. I'm going to just give that person a call and just see what's going on. And same type of concept. We can be very proactive, but use these mechanisms for us to be able to intervene. And that's what's really exciting, that we're starting to see that we can apply these technologies that can be done in ways that are very consumer-centric, that are compatible with one's lifestyle, but at the same time can provide us information that can be used to improve health outcomes. So thank you very much. I'll take any questions. Does the video work?
I'll try to.
Okay, well, we'll give it one more chance. Okay. Any questions? Yes?
I noticed that you are into enterprise, which is business to business. Many of these things look like they're business to consumer, because when you focus on things like pain reduction, and it's at 70 sites that are academic, what is your plan, to really make it business to business? Because it is literally just kind of staying in this segregated academic community or something else. It'll take a lot for it to make it a business to business. Right now it seems like everyone watching here would be like, wow, that's great, business to consumer.
Well, in this moment, I just took a pain pill.
I think everyone in this room would be like, that's great, business to consumer, way to go. But your focus is business to business. How do you leverage this? How do you make those things go?
So it's actually a strategy and a roadmap issue. So what we realized is that you can't bring technology to consumers and just say, here it is, it'll work, trust us. It has to be validated. And so in our validation, we've had to work very closely with healthcare organizations and payers and understand how we can establish that network. Once you get it to the point where it actually is shown to work, you've got providers saying that it works, and you've got payers willing to pay for it, you can then flip the switch, provide this in your local retail store on your e-commerce. It's a highly effective way for us then to be able to let consumers know this is something that everyone agrees works, but now we're giving you access to it. So a good example is when we started the exploration with the virtual reality for pain management. These are individuals that were hospitalized, had never been exposed to this before, and it's hard for them to even want to try something new when they're in acute pain. They tried it in the hospital and had amazing results. I mean, we've had kids with sickle cell pain crisis come into the ER. Traditionally, these are folks who get admitted, start on IV narcotics, discharged a couple days later. literally from the ER, given IV fluids, VR, sent home, no narcotics. Post-op women, delivering babies, no epidurals, using the VR. Post-op pain management, not using the epidurals, or the management. And what we realized is that if they don't experience it, they're not going to know what until it gets to the point where it actually becomes so widespread that everyone knows about it. At this point, we're recognizing is we have to introduce it to them in the context of a clinical experience. But once that starts occurring and people start becoming aware of this, then it becomes very much of a consumer application. But we know that we have to kind of go through this process.
But
Yeah.
what I'm asking you, David, is do you think, for example, the way to leverage this and mechanize it is in business enterprise is to take, for example, the virtual reality goggles for pain or whatnot. Do you think it's to distribute it through Kaiser? I mean, would that be the business-to-business model? Because obviously you don't want to get involved at Samsung in doing hand-to-hand combat, business to consumer. That's just bloody and forever. So, what is your roadmap?
So starting with organizations like Kaiser and a variety of others that will embrace the technology, really introduce it to their own members or their own patients, and then from there, once there's a greater awareness of this, then at that point it becomes something that we can enable the end user to be able to eventually gain access to. Many of these are low-cost solutions that are easily to implement at home, but to expect someone to really know what it is, and expect them to use it when they have a certain situation, highly unlikely that they would, especially if their doctor's never heard about it and it doesn't even in any way have a recommendation on it. If it comes from the doctor because it's been used and is shown to be effective to you, so let's say you take in some cases though, you go to the doctor and there's not a whole lot, like the macular degeneration. You've went to the doctor. They gave you these injections and it's still not getting better. And at that point, and we've actually seen this is where we have said, well, you know what, try this. And in remarkable number of cases where people have said, you know what, I was kind of at wit's end and this is actually working. And in those scenarios, yes, because people have kind of exhausted the normal channels, but it depends on the scenario. I would say in general though, there needs to be a real good understanding of how it works in clinical practice. So I think
is it the same strategy as pharma? You introduce a drug and then it becomes a consumer product, over the counter.
Yeah, I think so. Yeah, because if let's say a drug was released and it was never FDA approved and none of the docs had ever done a clinical trial on it, well, first of all, it would never be launched or never be approved to show on TV. But that's the type of thing. You really have to kind of make sure it's gone through the mechanism where it would be something that, talk to a doctor about this because, well, doctors know the clinical trials support it. They've had their own experience with it. And that's really kind of a key thing. If you want to get newer technologies, these disruptive technologies to be widely adopted, you either have to make it so obvious and easy for the consumer that there's a no-brainer, or you're going to have to find a way to make sure that they understand that this is something that is truly a breakthrough innovation that is supported by the medical science and your clinicians. So to that point, we're going to show a quick video here that gives you a sense as to kind of what the possibility of VR is in potentially treating the opioid epidemic, if we can get this.
You haven't tried virtual reality before?
No, I never.
How are you feeling?
Well, in this moment, I just took a pain pill, which I don't care to take.
We have this instinct in America to treat things with pills, and that can lead to dependency. There's got to be something else we can do. Okay, let's see what happens here. And what we found was that virtual reality can significantly improve somebody's quality of life.
Oh my.
Virtual reality is powerful because it's as if the VR has temporarily inoculated the brain against pain. With virtual reality, we've seen a 50% reduction in pain. So do you feel like you're in a hospital now, or?
I definitely forgot I was in the hospital.
I'm Brennan Spiegel, Director of Health Services Research for Cedars-Sinai. If I see any new biomedical innovation, whether it's a technology or otherwise, my first instinct is it's not going to work. That's the null hypothesis. That's what science is based on. As of 3 years ago, I hadn't even heard of virtual reality. Matt Stout and the Applied VR team came in and they told me about this technology that sort of nudges the brain.
What you're going to do right now is a virtual reality experience that we've created to demonstrate the ability of VR to hijack the brain.
And they had me stand on top of a building. And my brain was hijacked. My brain thought, I am about to die. And they said, just go ahead and jump off the building. Just leap off. I said, no chance, I'm not going to do that. And I said, well, you know that your feet are standing on carpet, right? And I said, my feet know that, but my brain doesn't know that. I could not disambiguate this virtual reality from real reality. And I realized at that moment that this was a technology that can overwhelm the mind, and it could be used for evil, but maybe it could be used for good also. You know, we talk about virtual reality like it's one thing, but VR, the headset, is like a syringe. What I mean by that is, what matters is not the syringe, what matters is what medicine goes through the syringe. What is the patient seeing, feeling, hearing, experiencing? That's the therapeutic arm of virtual reality.
I don't know how we do this, but it would be great to figure out if there's a way to build a sensor into the headset. It relaxes them to the point where they can start to fall asleep. Dr. Brendan Spiegel has been an amazing partner for us. We're using immersive technology to help address the pain crisis in America.
Opioids are now the biggest drug epidemic in American history.
If you have a major operation or any kind of surgery, or even if you haven't had an operation, you get a pill. If you take 1 day of opioids, there's a 6% chance you'll be dependent on it 12 months later. That's how powerful they are in causing dependency.
Recently, I was in the hospital every month. I had extreme pain. So I'm on like 30 different medications right now. There comes a point when you're taking so many meds, it almost feels like nothing is really helping. We had to do something to change the situation. And that's actually where I met Dr. Spiegel. They were doing the trial project for the virtual reality program. Oh my gosh. The breeze is blowing through. There's the Hollywood sign. And there's my house.
In that study, we found that it runs interference in a way that affects the way the brain is experiencing the physical phenomena of illness.
Thank you so much, Sai. You have no idea. Dr. Spiegel's team is doing some incredible things. When I'm in there, I forget about my pain, I forget about what I'm going through. It allows me to go even longer without taking my pain meds.
People ask, what happens when they take the headset off? Do they then need the opioid? And what's so fascinating is the answer is no. It hasn't cured the underlying disease, but for a period of time, the brain is in a different place. How are you feeling? I heard you had some abdominal pain, is that right?
Yeah. The medicine wears your body out.
Yeah. See if that's comfortable on your face. Let me know what you're seeing.
I'm in the water with the dolphins. Oh, wow. My back was hurting before you guys came in here.
Does this help at all?
Yeah. This is not hurting now.
We've had now almost 2,500 people at Cedars-Sinai receive therapeutic, immersive virtual reality. And it's amazing to me if I think back to jumping off that building to see just how this has exploded. And for us to be able to provide a little respite for somebody suffering from pain without having to turn to a pharmacotherapy or an opioid, that's compelling. Back to real reality for a second. With virtual reality, we've seen a 50% reduction in pain.
We're also looking at ways we can bring in what's called a haptic device, something that actually can vibrate and bring in the sense of touch. The more senses we can immerse, the more powerful we can make this therapeutic.
The most amazing things I realized after using the virtual reality is that I could take my mind off the pain.
The goal is not for people to be in VR forever. The goal is to train the mind with increasingly sophisticated techniques to appreciate real reality, having a different mindset upon re-emerging into the world. Just like mindful meditation, there's just a new way of tweaking the mind to become sort of super better in essence.
Okay, any other final thoughts, questions? All right, oh, yes.
Is this watch, Rhew, is it available in the commercial market right now?
It is. There's actually two watches. One is called Mobile Help. That's available also, and that's a PERS system designed specifically for seniors. The Rhew is a similar one, slightly different form factor, but they're both available, yeah.
You give a pretty good example on the combination of visual and pain and brain. Apparently, I guess 90+ percentage of person's disease in the human body comes because of mind, apparently.
Yeah.
So if that's the case, is there a way to use technology to clean up the mind for the thoughts that cause the pain and issues to come in the body can be reduced or eliminated before it becomes physical ailment in the human body? Is there a possibility in the future, maybe not right now, but a thought along that line?
Like preventing pain before it happens, right?
Well, I mean, I'll tell you something similar. It's maybe not exactly what you're thinking about. Well, we've used, researchers have used this for post-traumatic stress disorder. And what they've found is that by doing these exercises, it does help prevent those episodes from occurring. So when a person does go into a certain environment and they hear loud noises or they're surprised, it doesn't elicit that same prior response. They've actually now desensitized them through this process. So we do know that you can retrain the mind in ways that allow you to have a different physiologic response. It's being used for stroke management. It's being used for a variety of medical conditions. So the amount of innovation in this space is remarkable. I think one of the most remarkable studies I've seen, this was published in Nature last year, you had 8 individuals with spinal cord injury. They're chronic paraplegics from the waist down, loss of bowel and bladder. These are individuals for some who had been paralyzed for as long as 13 years. These are individuals who were giving a VR headset with an exoskeleton to help them walk. They had a 1-year treatment in which they tried to retrain the body. And at the end of that treatment, all of them actually, at the end of follow-up, were upgraded from complete paralysis to partial, which is remarkable because some of these individuals had been paralyzed for 13 years. So it's incredible that you could actually envision an ability to restore neurologic function. And the way it's working, if you can think about the spinal cord as being consisting of major and minor pathways, you got big neural paths and you got sort of minor ones. When you have damage to the major ones, which were the ones that we are so used to managing our large motor function, we oftentimes feel that there's not a whole lot you can do. But the dormant, inactive minor pathways, which we've never used, are still potentially viable. And similar to what we talked about with the AMD, when we sort of retrain the individual so that you've got strong signals coming from the brain down and you're moving the foot and it's feeling the sensations coming up, you actually can somehow reconnect that. And that's what they saw. They saw that in this study. It was published in Nature, which is phenomenal because I feel like even things that we had visioned that there really wasn't a whole lot of hope for, we're seeing benefit. And also in that group, they saw restorative function on the bowel and bladder, which you wouldn't have anticipated because they're not in any way exercising it, but it's just the fact that they're starting to regain neural function, it started to have a regenerative effect. So a lot of neuroplasticity that is being leveraged. The fact that this is happening even after multiple years is remarkable. All right, yes, question?
Yeah, I have a question. Very impressive company. For the VR and no VR study, you have the functional MRI images. So for the case of no VR, what is the patient looking at? Are they looking at some images or?
So in the randomized control trials, so the question is about like what about the patients with no VR? So in the randomized control trials, they actually watch the same type of content on a TV screen. So the study in the RCT was designed to make it as difficult as possible to show a difference between the two groups, and yet they still saw 52% reduction in pain. Now in the functional MRI, they took a baseline of individuals that before they got the VR, they did the functional MRI, and then after they did the VR, they showed the change. So it was really more of a before and after as opposed to no VR and VR. Okay. All right.
If someone suppose playing a video game or something, like distracting the mind, kind of very focused on the game, do you expect some changes?
Interestingly, in kids, we do see some effect. Kids seem to respond differently than adults to the VR and their receptiveness to video games. So that's one where we are starting to see that there might be some different mechanisms of action for kids. But generally speaking, adults tend to respond more to the calming videos as opposed to the video game interaction.
And like now that the VR is like available like in the mall and everything, how do you distinguish a patent in this product compared to that?
I didn't share the data, but there are some studies that have shown a stepwise progression. So if you took just generic VR, we'll call, there actually is benefit to that. But curated VR, specifically with the music and all the other things, has an even higher level of efficacy. So if you are using this for true clinical purposes, you probably want to go with the one that has been shown to work. I mean, you might get lucky and get the right combo of, video and, and sound, and it could be effective. But the reality is, if you want this to be used on a consistent basis with multiple patients, you're probably going to need to at least start with the ones that work. And then maybe, who knows, over time you could switch to things that are free and publicly available, but we just don't have any data on them.
Because there is a lot available, like these relaxation musics, or you can say, like, meditation musics or whatnot, and they can be combined with.
It's very possible it could work just as well. Yeah, so there's nothing magical about the content. It's just that the content has been tested, and there is a certain amount of understanding that this meets certain types of qualities or characteristics that have been shown to be effective. But that said, one other important element is choice. You allow the individuals at the very beginning to choose which ones they feel is they're most desirable. That's an important aspect.
So what's the AI aspect of this? It sounds like it's like generic for everyone. So when we are talking about AI, we're talking about like more individualizing it, or applying it to a bigger population with more data.
So there are a few things that are going on right now that are part of this. So we were recognizing we have a potential treatment option. What we're starting to look at, and this is a study that we're doing with Travelers Insurance. It's a large provider for workers' compensation. And they're doing a study to look at what we call a digital pain reduction kit. And as part of that, there's a wearable, there is a VR headset, there's a Bear TENS unit, and there's an ability for the individuals to also to synchronize their breathing and their pulse as they're watching it. And so what we're trying to do is we're trying to teach individuals how to apply some of these mindfulness techniques. And then we're also looking at some point to be able to do a correlate for their pulse or aspects of the pulse to see if that could be a mechanism to assess pain virtually. So rather than asking them, did you resolve your pain, could we actually then assess them using these surrogate markers? So there's a whole lot of work currently being done to see if there's ways that we can truly create a virtual experience without having clinicians be there and asking all the questions and doing all the things for them, but really making it self-sufficient.